Hi, my name is John Meliones. I'm the director of the Pediatric Cardiac ICU at Duke. And today I'm going to talk to you about congenital heart disease and respiratory failure and talk to you about some of the approaches and techniques we use to manage these patients. So we'll talk about some of the systems that are involved in cardiac care. We'll talk about the pathophysiology, about what's parenchymal injury and vascular injury and how this can occur in congenital heart disease. And then we'll talk about when you have a problem, how you direct a therapy at this that's pathophysiologically directed, not something where we just use the same methodology for each patient. So what do we know? We know that there's about 25,000 babies born each year with moderate to severe congenital heart disease. And surgical correction and palliation is dominant within the first year. It used to be that many of these patients were either not operated on or were operated on later in life with palliation. Now we're going to a more complete repair because we know that this may have better neurological outcome. But what do we do in these patients? We expose them to systems, called cardiopulmonary bypass. So if you were to bring your patient in and you had a mother and you tried to get consent, what would you say? You'd say the following. First thing we're going to do is we're going to open up the chest and we're going to put tubes in. We're going to put tubes in the arteries and tubes in the veins, and then we're going to cut off all the circulation so there's no blood going through the heart. Then, because we know that a high hemoglobin is bad in this situation, we're going to take a lot of the blood out and make your blood count very, very low, and you're going to hemodilute. After that, we know that we're going to have to do work on the aorta, and therefore there's a risk for brain injury. So we're going to use hypothermia, so we're going to freeze the baby. And then we sometimes do low-flow bypass where we take another cannula and put it up into the brain and provide a little blood flow. And then finally, after all that, we're going to reperfuse it. We're going to give the heart perfusion again and the brain perfusion again, and we're going to reverse all these things because we know all these things are bad. Now, would you sign consent for that? Probably not. Okay? But these are all the system things that we do, and there's a tremendous amount of systems involved in providing surgery to congenital heart disease, and this is going to lead us to injury in the lung parenchyma and the lung vasculature. So what are the systematic effects that we see? There's many changes that occur that complicate the management of congenital heart disease. Pro-inflammatory, pro-thrombotic, and oxidative stress pathways. Systemic inflammatory response and diffuse capillary permeability continues to cause problems with organ dysfunction, and we know this from many studies that are out there. There was one study that was very nicely done in 2006 that showed that infants and neonates are more susceptible to the inflammation that occurs following cardiopulmonary bypass. If you look again at the changes in congenital heart disease over the last 20 years, and you looked at the patient population, it used to be that 60 to 70% of the patients in the ICU were in the adolescent age in the cardiac ICU for surgery. Now 60 to 70% are in the neonate age. So the majority of your patients are neonate, so the majority of these patients are going to have very high risk for systemic effects of cardiopulmonary bypass. When we look at this is pretty well understood that there's a peak inflammatory effect around 4 to 6 hours post-cardiopulmonary bypass, which is preceded by oxidative stress. And cardiopulmonary bypass creates hemolysis, which generates oxidants, increasing vascular permeability. And then this hemolysis is more severe in infants. Why is it more severe in infants? Some of this is just based on the physical differences between neonates and adults. There's greater relative exposure to non-endothelialized surfaces. We have situations where adults don't have, where we have ischemia and reperfusion. So we reperfuse the lungs and the brain as well. Again, we have small cannula size, so you have increased mechanical stresses, and sometimes the cardiopulmonary bypass circuit is primed with stored blood. So all of these stressors, which may not be present in the adult patient population, are present in neonates. So that's why they're at much higher risk for this kind of problem. Do we know that this is true? Yes, there's a very nice study that was put out from the group in Boston, which looked at the effects of cardiopulmonary bypass over time. Look at 3, 6, 9, 12, 18, and 24 hours after cardiopulmonary bypass, and you look at cardiac output, cardiac index in yellow, and you look at inotropic score in blue, and what do you see? You see around 9 hours out, there's a very predictable reduction in cardiac output. And this is related to the inflammatory response that occurs. What you don't see is a response by the clinicians to treat this. And that's one of the things that we try to teach everybody, is that you need to anticipate this issue occurring around 3, 6, 9 hours out. And this is the inotropic score, and you see that there wasn't not a lot of manipulation in this, and this puts the patient at risk for an untoward event. So this slide here shows that yes, there is a predictable event that occurs around 6 to 9 hours out that we need to be aware of and we need to help treat. So what about the lung injury in infants after cardiopulmonary bypass? Well, there obviously is a lot of things that are going on in the lung, and surfactant inactivation is one of the most important components to it. There's interstitial and alveolar edema, and immature antioxidant defenses occur as well. And so patients have many different things that occur they have risk for cardiopulmonary bypass. There's been some nice data in 1997 that looked at the duration of bypass. When you come back from surgery, they always talk to you about how long they're on cardiopulmonary bypass for. So the longer you're on cardiopulmonary bypass, the more injury you incur. Also the younger age, as we talked about earlier. So more infants, babies, that's why we wait for a week or so that they can accommodate. So younger age is associated with that. And there's a lot of other factors that are elevated: TNF-alpha, IL-6, and IL-8. Is this a problem, and is this an issue? Yes. Early pulmonary dysfunction is associated with increased mortality, increased multi-organ dysfunction, and increased length of stay, and finally increase in mortality. This was shown in a very nice in a study in 2002, where they said that if patients have pulmonary dysfunction as defined by an AA gradient, those patients had worsened outcome. So this, as you know, we talked about the myocardial dysfunction that occurs with cardiopulmonary bypass. But if you combine that with lung injury as well, then your mortality and your morbidity is going to dramatically increase. So this is the kind of patient population which is the toughest for us to manage, and we need to define the systems and approaches we use to manage these patients. So let's talk a little bit about the parenchymal injury and the vascular injury. We know there's systems out there, we know there's systems we use to manage these patients, so let's talk about these components to it. So what about the parenchymal injury? So when we think about the lungs, you think about the alveolus as the parenchyma, right? The alveolum bronchial is the parenchyma, and then we think about the pulmonary vasculature. So there are two separate components to it that we need to be aware of. So there's surfactant dysfunction and inactivations we talked about, and then there's always some alveolar fluid accumulation. And then the inflammatory response, and as you know, you can see this host of inflammatory response that happens: complement activation, neutrophil activation and migration, obviously endothelial cell injury, which we'll talk a little bit more about, upregulation of TNF-alpha, and then finally, when you reperfuse the lungs, then you have further activation of neutrophils. So all of this is going on right now in the immediate postoperative period when the patient's myocardium is at its most vulnerable point in time. So we have a vulnerable myocardium and we have lung injury at the same time. So what does this look like? Well, if we look at, in this slide here, you look at your compliance, static compliance, and you looked at pre, post, and 30 minutes post cardiopulmonary bypass. This is a study that was done in 1996, has been repeated by others, and is still valid. And it shows that if you look at the groups pre, post, and 30 minutes post bypass, all of them have a reduction in compliance. Now there's two, people talk about circulatory arrest and low flow cardiopulmonary bypass, which one is better? And as you know, the jury is still out on which one is better from a brain standpoint. But what we do know is that low flow cardiopulmonary bypass, because again, one of the reasons with low flow cardiopulmonary bypass, we're not going as cold as we do with circulatory arrest. And so because of that, the low flow cardiopulmonary bypass group has a worsened compliance than the deep circulatory arrest group. Most group are doing low flow cardiopulmonary bypass. So we are beginning to see even more respiratory failure in those kinds of patients. So you have to be aware that you will have a predictable reduction in compliance, and it may be worse in our patient populations that have low flow cardiopulmonary bypass. One of the things that I want to express to you is that not every patient is going to have the same kind of injury. And so there's different patients will have different kind of physiology preoperatively, and so when they go and have their operation and are exposed to all the systems, they're going to have different postoperative changes. So this is a study that looked at tetralogy of flow patients and VSD patients preoperatively, after the chest is closed, 30, 60, and 90 minutes post-op. And what do we see? It's looking at the functional residual capacity of the patients. And you see that the VSD patients had a very dramatic reduction in functional residual capacity. Okay? Whereas the tetralogy patients didn't have quite as much. Why would that be? Well, the VSD patients have what we call a loaded parenchyma already, right? Because they have congestive heart failure, and there's a lot of fluid already in the lungs, there's a lot of inflammation, they might have the beginning of a surfactant deficiency. So that's a loaded condition. And so when they are exposed to the system, they have a worse response to that. So tetralogy flow patients may not have as significant a reduction in functional residual capacity, but the VSD patients do. And so as you begin to think about the physiology of your patient, you begin to think about loaded circuits and non-loaded circuit. This is a loaded circuit, and the compliance falls. This injury has been looked at not from just a compliance standpoint, but is there an AA gradient? And so again, we're looking at pre-cardiopulmonary bypass in yellow, post-cardiopulmonary bypass in blue, and you see that in both groups, circulatory arrest group and low-flow cardiopulmonary bypass groups, they both have a very significant reduction in AAO2 with a significant alveolar gradient. What do we see? Again, notice the low-flow cardiopulmonary bypass, which is the preferred methodology for most groups now, causing a worsening of the lung injury. And now this is the true AA gradient here, and you look at the AA gradient in the circulatory arrest group and the AA gradient in the low-flow cardiopulmonary bypass group, and you see a very dramatic AA gradient. So this is suggesting that there's a very significant alveolar gradient related to just a simple system of cardiopulmonary bypass, related to the inflammatory response that occurs, surfactant washout, and the edema. Well, what about airways resistance? Because we talked about the parenchyma, we said that's the alveolar and also the airways. Okay? Well, this looks at the same study that looked at tetralogy of flow patients and VSD patients. And you notice preoperatively, chest closed, 30 minutes, 60 minutes, and 90 minutes. And what do we see? Well, the VSD patients, interestingly enough, have a reduction in airways resistance, whereas the tetralogy of flow patients have an increase in airways resistance. Why would that be? Well, in the VSD patients, what are we doing? They have a loaded pulmonary vasculature as well, and so the vessels are big, and they cause some obstruction on the airways. And so when we close the VSD and reduce the volume load in the pulmonary circuit, we actually have a reduction in airways resistance. However, the tetralogy of flow patients, what do we know about them? We know tetralogy of flow patients have small airways, and so any kind of edema in the airway is going to cause an increase in resistance, because in tetralogy of flow patients, the pulmonary arteries and the airways grow together. So if you have low flow there, you'll have smaller pulmonary arteries and smaller airways. And so these patients are at risk for high airways resistance. So what do we say? Two different patients, a VSD and tetralogy of flow patients, both have different physiological problems. So you can't use the same methodology for every congenital heart disease patients. Both of these can be done as a neonate and have two different outcomes and two different managed strategies. So as Yogi Bear said, you see a fork in the road, take it. So we're going to change our methodology here. We're going to talk about something else, vascular injury. This is what we think about a lot in congenital heart disease, pulmonary hypertension. I want to remind you that in a publication in the 90s, pulmonary hypertension caused 60 to 70% of mortality in the postoperative period. Most of us would say, wow, that's incredible, because we hardly ever see that as causing mortality. And so because of the effects of cardiopulmonary bypass, anesthesia has been continued into the ICU. We do a lot more anesthesia in the ICU, and so we have a lot less pulmonary hypertension. But it still is present, and it still causes a significant amount of morbidity and mortality. And it's something that I think we have a tendency to underappreciate, because we've done so many things to try to improve things. But what is this injury? Well, When we put a patient on cardiopulmonary bypass, we have injury to the endothelial cell. You know the endothelial cell, right now we are all breathing off a certain amount of nitric oxide in our body through our lungs because our endothelial cells are producing it. If you're not producing that, if you have endothelial cell injury and you don't have nitric oxide, then you're going to have smooth muscle constriction. This is the same type of thing that happens with alveolar disease. When you don't have oxygen coming down in here and you decrease your alveolar O2, then you're not going to have the ability to generate nitric oxide as well. And you're going to have increased pulmonary vascular resistance. And so both ARDS and cardiopulmonary bypass will result, an end result of decreased nitric oxide and therefore smooth muscle constriction and pulmonary vascular resistance issues. So what data is that on in congenital heart disease patients? Again, this looks at pulmonary vascular resistance, pre-cardiopulmonary bypass, post-cardiopulmonary bypass, and 30 minutes post-cardiopulmonary bypass. Again, the groups are circulatory arrest and low-flow bypass. And what do we see? Pulmonary vascular resistance increases dramatically just as effect of cardiopulmonary bypass. And it's worse in the low-flow bypass group. So again, I've said to you, pulmonary hypertension was a big deal many years ago. It stopped being a big deal for a period of time. Now it's becoming more prominent as we're beginning to move our methodology to low-flow cardiopulmonary bypass. Okay? Because low-flow bypass, one of the main issues with it is not as cold. And so if it's not as cold, you don't have as much protection of the lungs. So let's talk about, we've been through the systems. We know that there's cardiopulmonary bypass. We know there's hemodilution. We know that we're doing circulatory arrest. We know that we're doing hypothermia. And we talked about the different types of injury. We said there's a vascular injury, and we said there's a parenchymal injury. The parenchymal injury can be both in the alveolus, or it could be in the bronchus. Now let's talk about pathophysiologic-directed therapies. Is being in the ICU on a ventilator an issue? This looked at a study that we looked at the length of stay in the ICU and how long they were on the ventilator. And so what we were able to show in this is that 76% of the length of stay was directly related to being on the ventilator. So if you're not on a ventilator, you're out of the ICU in the majority of situations. Okay? So being on the ventilator is an important component of managing these patients, not just from a mortality standpoint, but from a morbidity standpoint and from a cost standpoint as well. So let's talk a little bit about the heart-lung system. This is can be a slightly complicated slide, but if you break it down pretty simply. So the SVC and IVC passively bring blood into the right atrium. The right atrium pumps it into the right ventricle, which then pumps it out to the lungs. The lungs then bring it around, of course, into the left atrium, left ventricle, and out to the aorta. And there are certain spaces in there. Of course, the internal space here is the pericardial space. Outside of that is the interthoracic space. And you'll notice, of course, the lungs are in the interthoracic space, but where's the aorta? The aorta is outside the thoracic space, right? And the SVC is outside as well. So one of the basic fundamental points is to think about is that the right ventricle is going to pump its blood where? Into the interthoracic space. Okay? The left ventricle is pump its blood outside the thoracic space. So a methodology for the right ventricle shouldn't be the same as the left ventricle, right? Because they're two different, they're pumping into two different areas. Okay? And that's the fundamental principle of managing cardiorespiratory reactions, to understand that the right ventricle is in the thorax and the left ventricle is outside, pumping outside the thorax. And so when you understand that, then you can understand how to manage these patients better. So now remember, again, interthoracic pressure is going to do what? Remember, here's the right ventricle, here's the right atrium. When we increase interthoracic pressure and squeeze in on the right side of the heart, because it's passive filling from the right atrium, from the SVC into the right atrium is in the thorax, the pressure in the thorax is going to increase, and so therefore you're going to have less flow into there, so you're going to decrease preload. So there's a preload reduction to the right side of the heart. Okay? Next thing you need to see is that what else is happening. Now the right ventricle has to pump into a pressurized circuit. So it's going to have an increased afterload. Right ventricle, decreased preload, increased afterload. Is that good? No, that's not going to be good for the right ventricle. So increasing intrathoracic pressure is always bad for the right ventricle. It's never good. And so if we look at it, where we're just looking at this right side of the heart, you see that the right side of the heart is compressed by the increasing intrathoracic pressure. We used to think it was the peak pressure, and over years we've realized it's really the mean airway pressure. So if you increase the mean airway pressure, no matter how you do it, PEEP, PIP, I time, whatever you do, you're going to limit flow to the right side of the heart, and you're going to increase work on the right ventricle. Now that's okay if your right ventricle is totally normal, like most adults. But what percentage of congenital heart disease have right ventricular dysfunction? A majority of them, right? So that's the main thing that we're looking at is RV dysfunction. So when you look at this and you see where we're at on the course, you see that when the right atrial pressure is low, let's just say the right atrial pressure is 5. You have this much return. Okay? This is systemic venous return here. This is right atrial pressure here, right? If your right atrial pressure, if your SVC is 10 and your right atrial pressure is 5, then you have this much amount of return. Okay? If I increase my mean airway pressure from 5 to, let's say, 15, and I therefore increase my right atrial pressure concomitantly to 8, for example, now I only have, instead of a 5 millimeter pressure gradient, I have only a 2 millimeter pressure gradient. I do what? I decrease my systemic venous return. The ventricle can't pump more than it gets. If you decrease the amount of volume to that ventricle, it has to decrease its cardiac output. Okay? So this is just a very simple example of that. And if my pressures are higher and my right atrial pressure are higher than the pressures in the systemic veins, guess what? There's no flow. Because it's a passive flow. So this is a very important diagram, and it really explains pretty much the majority of all cardiorespiratory interactions, that it's related to lack of filling on the right side of the heart. Because even if the right side gets it over to the left side, and the left side can kick it out, if you've decreased your preload by 30%, your cardiac output is going to have to fall. Okay? So what do we know then? We know that increases in thoracic pressure will decrease cardiac output. It's going to dramatically decrease preload, and it's going to also increase your afterload. And so this is going to be very, very important, specifically, for example, Fontan patients, single ventricle patients, bidirectional glands, tetralogy of flow patients, anybody with RV dysfunction, anybody who's susceptible to increasing pulmonary vascular resistance. So the best strategy for the right ventricle is to limit your intrathoracic pressure. That's simply stated. Well, what about this situation here? This is a left ventricle that's working well. How about this one? This is a left ventricle that's not working well at all. So it's very abnormal. Let's take a look at the thoracic changes in the left side of the heart. So now this is different. Over the right side of the heart, we saw everything being compressed. Now on the left side of the heart, the lungs are being compressed, right? If you compress the lungs, what happens to the blood? The blood moves somewhere, right? It's like a sponge. Step down on it, what's going to happen? Something's going to go out. And where does it go out? Well, one of the ways it goes out is into the left atrium. Okay? And so it'll actually increase the amount of flow. In fact, in the old days, before we had ICDs and all that, and patients who had arrhythmias, we used to teach them to cough. Because when you cough, you'd increase into thoracic pressure, and you potentially would reperfuse your coronary arteries and get out of your lethal rhythm. Nowadays, we have all these great tools and techniques and put in new devices and stuff, so we don't teach that as much. But this is a very important component to it. So that's called almost, a lot of people call this a thoracic pump augmentation. You squeeze down in the lungs, blood fills into the left side of the heart, fills up the left ventricle, and now the left ventricle can eject it. And now the left ventricle is going to eject outside the thorax, right? So this is very, very different than what happened on the right side. The right side is getting hurt by positive pressure ventilation. The left side looks like it's, at least in this point in time, helping it. This is a nice cartoon picture of this. When you increase into thoracic pressure, you push down on the lungs, the blood that's the capacitance that's sitting in the lung will then go into the left atrium, increasing left atrial filling, which will be able to kick to the left ventricle and do what? Increase left ventricular preload. So here we are showing that the left side of the heart is benefiting from the standpoint of a preload by just positive pressure ventilation. Okay? This is a little bit, if you look at, so here's the left ventricle and left atrium, you see during positive pressure ventilation, it increases in its capacity. Well, what about the effect on afterload? People have heard we talk about pulsus paradoxus many, many times. So pulsus paradoxus is what? It's when you take a cough or a deep breath in, and what happens? Your blood pressure drops. And why does that occur? That occurs because if you have a big negative in thoracic pressure, and you're trying to generate, in this situation here, we're trying to generate 100 in my aorta out here, my brachial artery, I want to generate 100. So if I have a negative 30 in my chest, my ventricle has to generate 30 just to get over that pressure, and then the other 100 to reach that. So that's why the ventricle, the transmyocardial pressure gradient is going to be 130 here. Normally, in all of us right now, as we're breathing, our blood pressure will dip a little bit as we breathe. When you have patients who are breathing excessively and excessive work on their breathing and excessive intrathoracic pressure, they'll drop their pressure so high that you won't be able to maintain that pressure. And so you'll have a very significant reduction in arterial pressure. And if it's greater than some number, some people say 10, some people say 15, but certainly if it's greater than 15 and a drop in your blood pressure, that's called pulsus paradoxus. Okay? It's actually a normal exaggeration of what would normally occur. So negative intrathoracic pressure is bad for the left ventricle, right? Because it causes the left ventricle to work harder. This was many, many years ago when we were using negative coraces on patients and single ventricle patients. We realized that a single ventricle patient acts more like even if it's a right ventricle, it acts more like what? It acts more like a left ventricle because it's pumping its blood to the aorta, not into the pulmonary circuit. So a single ventricle thinks like a left ventricle, not like a right ventricle. And so we had a lot of problems with negative pressure ventilation in those patients until we realized that physiology. So negative pressure, bad for the left ventricle. But what about positive pressure? So if I pressurize the thorax to 30 and I want to generate 100, I don't need to generate 100 in my ventricle. I only need to generate 70 because it's additive. So positive pressure is what? It's going to improve LV. And we say that we talk about this, we say that positive pressure ventilation drops left ventricular work or left ventricular afterload. So if we go back to here, and we said, okay, the left ventricle is sitting in the thorax during positive pressure ventilation, we're going to what? Increase preload and then drop afterload. Positive pressure ventilation, good for the left ventricle? Yes, it is good for the left ventricle. Positive pressure ventilation for the right ventricle? Bad. Okay? And this is important because when you start thinking about what is the problem with the patient, I think we're going to talk about Fontan patients in a minute, thinking about what's wrong with the patient. Is it the ventricle that's wrong with the patient? Is it the pulmonary vascular that's wrong with the patient? Is it the right ventricle? And that way you can determine the appropriate approach to it. So patients with left ventricular dysfunction benefit from positive pressure. So what are the effects of positive pressure on the left ventricle? Increase in thoracic pressure may actually increase cardiac output. It may increase preload when it's low and should decrease afterload. Some people actually use positive pressure ventilation in patients who have cardiomyopathy to help try to limit the amount of preload that's coming into that ventricle, and so that also will improve output as well. So the best strategy for the LV is to optimize your positive pressure by increasing your thoracic pressure, not to limits which exceed normal, however. When we teach people to do this, we want them to make sure that they're not using exorbitant peak pressures or exorbitant tidal volumes. There used to be an approach that people use where they use 10 to 15 delivered per kilo tidal volume, and we found that created a lot of chronic lung disease. So you want to utilize your positive pressure for the left ventricle, but you don't want to be so exuberant that you cause lung injury. That's an important caveat. Let's talk a little bit about pulmonary hypertension, and the reason why I want to spend a little bit of time on pulmonary hypertension is that, again, remember that it caused 60 to 70% of all mortality in the postoperative period, and now is much less. But still, even now, as we all know, in recent days, that pulmonary hypertension can result in mortality. So let's talk a little bit about this. So pulmonary hypertension does what? It simply causes vasoconstriction of the pulmonary vasculature and increases the workload on that right ventricle. Okay? And the problem with this is if you get into a pulmonary hypertensive cycle, we get what's called a pulmonary hypertensive crisis, that things happen very quickly. And that's why you have to jump on this very aggressively. So that you have increased RV afterload, you can have RV failure. you have low cardiac output syndrome. You're going to increase your RV end diastolic pressure, you're going to decrease flow going to the left side, and you're going to get RV ischemia and arrhythmias. Okay? Once you get low cardiac output and you get metabolic acidosis, what happens next? Then you have more pulmonary hypertension, worsening RV function, and then more acidosis. You're also going to get, with pulmonary hypertension, decreased pulmonary blood flow, you're going to get VQ mismatch and hypoxia as well. So if you're waiting to see hypoxia for a patient with pulmonary hypertension with a two-ventricle pair, you are way too late. What is one of the earliest signs in this situation is the increasing end diastolic pressure. So your CVP, your right atrial pressure, if that's going up, then you know you're in big trouble. Because while we used to put pulmonary artery lines in almost every single patient, most people are not doing that anymore because they think that the risks associated with that outweigh the benefits. And so as surgeons get less used to putting those lines in, they become less interested in doing that. So in the old days, almost everybody would come out of the operating room with the pulmonary artery line in place. Now, you know, with catheter-associated bloodstream infections and all the things that we're doing, we're trying to reduce the amount of lines. So you won't have a direct measure of pulmonary hypertension, but you will have a CVP. And so when you see that CVP go up, and you see your oximetry going down, then you know you're starting to develop this process. And you need to jump on this very, very aggressively, because that metabolic acidosis and low cardiac output is going to be an unrelenting cycle that's tough to break. How do we measure pulmonary hypertension? This is an echocardiogram where we're looking at a Doppler tracing from the right ventricle to the right atrium. And what we're looking at is when the door opens and the right ventricle contracts, how much pressure does it contract into the right atrium at? So, for example, in this situation here, here's the amount of blood that's leaking back into the right atrium. Now, the right atrium has some blood in it to begin with. So when the right ventricle leaks back, it leaks back only to a certain amount, because if the right atrial pressure is really high and the right ventricular pressure is not so high, there won't be a lot of leak. But when the right ventricular pressure goes very high, it'll shove blood back into the right atrium up to the pressure that the right atrium is. And so we can do some minor calculations. So then in this situation here, the TR jet, which is what it's called, tricuspid jet, is measured at 103. So we know that the right ventricle here is 103 higher than the right atrium. Okay? Because it can only, if the right ventricle was 5 and the right atrium was 5, there'd be no flow. If it was 25 and 5, you'd have a gradient of 20. So that's how we calculate the right ventricular pressure. So it's the 103 plus the pressure of the right atrium. And so if that's, for example, 7, then it's 110. So let's talk a little bit about mechanics. So what do we know about mechanics? And let's start jumping into our ventilation approach to these patient populations. So again, in summary, where we're at right now, we've talked about the right ventricle, doesn't like positive pressure. We talked about the left ventricle, loves positive pressure. We talked about the effects of cardiopulmonary bypass, how you can have a vascular injury and a parenchymal injury. The parenchymal injury is an alveolar injury or a bronchial injury. And it's different depending on what type of disease process you have. This is an example of looking at lung volumes and pulmonary vascular resistance. Okay? And as you know, when you collapse the lungs and you have atelectasis, you're going to have increased pulmonary vascular resistance related to hypoxic pulmonary vasoconstriction. So the larger vessels are going to clamp down. As you expand the lung to the best point is FRC, and when you get at FRC, you have the lowest pulmonary vascular resistance. The lungs are expanded, they're open, the FRC is perfect. If you overexpand the lungs and move and try to use high tidal volumes, especially high PEEPs in these situations, then you're going to squash the capillaries and you're going to have a dramatic increase, not a linear, but a dramatic logarithmic increase in pulmonary vascular resistance related to compression of the capillaries. Okay? This is going to be a very bad situation for you in patients who are at risk for pulmonary hypertension. Okay? Interestingly enough, what type of ventilation do we use at FRC? High-frequency ventilation. That's the goal of high-frequency ventilation, is to be at FRC. And so that'll allow you to ventilate the patients at the lowest pulmonary vascular resistance. So we look at our patient. This is a patient that we had who's had surgeries, come back 8-9 hours after surgery. Compliance is falling apart. And you look at, here's our airway pressure tracing here. and here's our volume here, and this is a pressure volume curve. And what you see is the PEEP set at a low level here, and so what you do when you try to put the breath in, you're just opening up the atelectatic regions of the lung. And then finally you're able to deliver the breath at the inflection point, and then you have exhalation. And so the PEEP is set at 5, the opening pressure is 17, and the PIP is 45. So what is a dynamic compliance? Dynamic compliance is the tidal volume of the PIP and PEEP. And we see in this situation here, we have a dynamic compliance of 1.9. So we're way, way down the curve here. This patient has a lot of atelectasis we're not treating appropriately. And so we need to titrate up the PEEP, okay, being careful, right? Because we know that increased mean airway pressure is not always the best thing for myocardium. But we want to titrate up the PEEP so that we don't have this kind of excessive alveol here. And we call this the cost of recruitment. What is the cost? How much does it cost? And in this situation here, it's a pressure of 12 to just recruit the lung and open up the lung. Now that's a pretty high cost. And so in this situation here, in this patient, they titrated up the PEEP, and they found that at a PEEP of 12, when the lungs weren't collapsing, because when the lungs collapse, it takes a lot of energy to open, and if you brought it to PEEP to 12, then you're able to get a nice curve with very low atelectasis, and the PIP dropped to 35, and now the compliance, which was 75 over 35 minus 12, 3.3. Compliance of 1.9, compliance of 3.3, peak pressure of 35, peak pressure of 45. Much, much better. And so that's why we encourage you to use your graphics very carefully on determining what you're doing in a patient in the postoperative period, because you would think that you would have needed a 17 of pressure. And if you just looked at this curve and you said, oh, I got to go to the inflection point and go at 17. But that's not necessarily true. If you allow the lungs to collapse, it's going to take more energy to open up. But if you don't allow them to collapse and you try to keep them open, it's going to take less pressure. Again, that's an important concept when we come to high-frequency ventilation, right? Because high-frequency ventilation's goal is to get the lungs open and keep them open and work on top of that. Okay, so you're seeing how we're able to ventilate this patient at a much better place, lower peak pressures, better compliance. There has been some studies with the use of PEEP and recruitment maneuvers in the postoperative period. This was a study in 2009 where they looked at end-expiratory lung volume, which is in our situation, that would be functional residual capacity. So if you look at that end-expiratory lung volume, and you see with 8 and 8 in a recruitment maneuver, you see a very significant improvement in end-expiratory lung volume. This was done after these cases. So immediately after the case, they would try these recruitment maneuvers. And if you go down to the OR, I don't know if anybody's been down to the OR, but when you go down to the OR and you watch the anesthesiologist try to recruit the lungs that have been collapsed during that time period, they don't simply bag it. They put them on a high level of PEEP, and they do a sustained recruitment maneuver for a period of time. Okay, so recruitment maneuvers in PEEP are very beneficial in improving lung mechanics postoperatively. But we have to be careful, don't we? When you look at this pressure volume curve, this is a nice pressure volume curve in the sense that the volume is increasing as you increase the pressure. But at this point in time here, we see something that's what's typically called terminal beaking. It looks like a beak. And what this means is now, at this point in time, I am increasing the pressure dramatically with very little return on volume. Okay? And so this is not great because it's going to cause over-distension. The reason why this is, sometimes you don't appreciate this as much as we used to. When we first brought graphics into this unit and we looked at our patient population, blinded to the clinician, 70% of patients had over-distension. Huge number, huge number. And that's, nowadays people are talking about low tidal volume ventilation, and most people are using low tidal volume ventilation. So you're not going to see a lot of this, but it's important when you have a patient who's critically ill, who's having some difficulties in the post-op period, you look at these graphics and make sure you're not causing over-distension. Because the cost-benefit ratio is horrible, right? A lot of cost with very little benefit. And so some people will do a measurement, the C20, which is the compliance over the last 20% of the breath, over the C100, over the total compliance, and you can look at a number, and that will tell you that you have over-distension. I like just looking at it. If I see this, I know we need to back this off. So here's your C20 over C100, and it's less than 1. Okay, anytime it's less than 1, you have a problem. Okay? What about the effects of pH on pulmonary vascular resistance? Many years ago, we talked a lot about the effects of pH on pulmonary vascular resistance. This is a nice study done in 1985, which we've repeated 17 times and it's come up with the same results. And you look at animals which had a pulmonary vascular resistance of this, you made them hypoxic, and the pulmonary vascular resistance went up. Of course, hypoxic pulmonary vasoconstriction. That makes sense. But what was great about this study is they showed that a respiratory alkalosis, remember what we do with respiratory alkalosis, you hyperventilate them. And a metabolic alkalosis, both resulted in a reduction in pulmonary vascular resistance. This is very important because many textbooks you'll look at, especially old textbooks, will talk about hyperventilation. And we do not want to do hyperventilation because there's been several studies since then that have shown if you hyperventilate the patient, what's going to happen? You're going to decrease cerebral blood flow. And in patients who have marginal cerebral blood flow to begin with, you have a very significant drop in cerebral blood flow during hyperventilation. So hyperventilation is no longer not only standard of care, it's no longer advocated at all, and you should never hyperventilate your patient below a CO2 of 30. Okay? So this is not an approach you should be using. If you want to use a metabolic alkalosis to improve your patient, that's totally fine, but do not hyperventilate. This is a nice study that was done in 1973. Ira and I wrote an article many years ago, and there was an editorial by him who said that I had already done this study in 1973, so I've scrapped my slide of it and used his slide because I think it illustrates things quite nicely. If you look at this side of the equation first, and this is going to be the change in CO2, dropping at 10%, dropping at 20%, dropping at 30%. So I'm dropping my CO2, but while maintaining the same pH. So this is hyperventilation, but not the pH effects of it. And what do you see? Here's the pulmonary vascular resistance. No change. So dropping your CO2, not only is it bad for you, because it decreases cerebral blood flow, but it doesn't work without a pH effect. So it's really the pH effect. So again, this illustrates, please do not do this type of approach. Now, what was also interesting and lost for many years in this study was this side of the equation here, where they increased by 10, 20, and 30% the CO2. And what do you notice here? Dramatic increase in pulmonary vascular resistance. Well, that makes sense. If I'm an alveolus and I have CO2 in it, I'm going to vasoconstrict because I don't want blood going to an alveolus that can't exchange CO2. So this is an important methodology that people use in some patient populations. Patients who are over-circulating, who have too much pulmonary blood flow, not enough systemic flow, will allow the CO2 to go up to decrease the amount of blood flow. The other thing that people use this for as well is what? It causes pulmonary vasoconstriction, right? But it also causes cerebral vasodilatation. So in patients with bidirectional gland who may have marginal CO2, marginal blood flow through their gland, you can allow the CO2 to go up to higher levels to promote blood flow to the brain and therefore more gland flow. So again, in summary, this is an important slide because it shows that dropping the CO2 independent of pH does nothing but hurt your patient, whereas allowing the CO2 go up can be used as a therapeutic modality to try to modify pulmonary blood flow. So here's a nice study that came out of CHOP in 2006 and looked at the PaCO2 and the cerebral blood flow, and shows that when you hyperventilate your patient and you drop your CO2, you have a reduction in cerebral blood flow during hyperventilation. So again, hyperventilation is not an approach that is recommended for any of these patients. What about overdistension? I talked a little bit about that earlier, and I said that in the old days there was a lot of overdistension. If you're not using graphics all the time in your patients, you will have overdistension, even at moderate tidal volumes. This is a study that looked at not delivered but set tidal volumes of 10, 15, and 20 mLs, and looked at the effects of PEEP. Here's the PEEP of 10, here's the PEEP of 5. You see, both had very significant increases in pulmonary vascular resistance when overdistension occurred. Okay, overdistension is occurring at 15 and 20. But the effects were much more dramatic as you increase your PEEP. So when you're getting your patients and you're putting them on high levels of PEEP and you're trying to increase the tidal volumes to maintain a normal CO2, you have to be aware that you may be hurting the myocardium by increasing the pulmonary vascular resistance. So it's important to really manage this carefully. What about the effects of cardiac output? Again, What did we say about mean airway pressure? Decreasing right-sided flow, decreasing right-sided volume, going to decrease cardiac output. So already you see, if you increase your PEEP from 5 to 10, you're going to drop your cardiac output pretty dramatically. And then if you overexpand on top of that, look at how dramatic this effects are. That's why, again, you must be using your graphics, and you must be looking at this very, very carefully, because these patients have marginal myocardium, marginal cardiac output, and we start to do things like increasing the PEEP randomly, we're going to embarrass the myocardium of its cardiac output. Now let's switch gears a little bit. We'll talk about some non-conventional modes of ventilation, high-frequency jet, oscillatory ventilation, and we'll talk about nitric oxide. So what is high-frequency jet ventilation? Again, it's intermittent pulses delivered of gas at high frequency. The nice thing about it is passive exhalation. So we breathe in, we breathe out, right? We breathe in, we breathe out. With a ventilator, you breathe in, and it's passive exhalation as well, right? It occurs passively. But the nice thing about the jet is passive continuous exhalation. And so it has tremendous ability to remove CO2. And so you can remove CO2 with lower work. And that's going to be the important component to it. In the past, it was limited by the need for a special ET2 adapter, but now with changes that have occurred, this is no longer necessary. There is some weight and size limitations, but we've been able to utilize this on patients as large as 30 kilos. So this is an example of a graphic that looks at conventional ventilation with its mean airway pressure. You see inspiration occurring, linear increase in airway pressure, and then exhalation occurs with a PEEP of 5 and a mean airway pressure of around 11. And then high-frequency jet ventilation. And what we're doing with jet ventilation, you see you're not allowing the pressures to drop as low, and there's multiple pulses, and so at a same CO2, we're able to drop the mean airway pressure. So instead of having a mean airway pressure of 11, we have a mean airway pressure of 8. So for the same amount of work, we're able to get more CO2 out. So that's going to be good for the right ventricle. And so if you look at the kind of patients where that might be helpful for, this is a patient here with tricuspid atresia, and is a single ventricle patient. And so what are we going to do with this patient? We're going to do surgery, and we're going to take this patient and make this patient a one ventricle surgery. Okay? And so therefore, all the blue blood is going to have to come passively through the lungs, down into the left atrium, and then get delivered by the left ventricle. So this is going to be a Fontan circulation. And the Fontan circulation is one of the most dependent on pulmonary vascular resistance. Because if pulmonary vascular resistance is elevated, guess what happens? You don't have as much blood flow. You don't have as much blood flow. You can't eject it. So this ventricle is only going to be able to eject what it gets. Okay? And so this is an old study that looked at high-frequency jet ventilation many, many years ago. And in this study, we looked at pre, during, and post high-frequency jet ventilation because it occurred over a period of time. We wanted to make sure that the patients weren't changing. And so you see, we were able to drop the mean airway pressure almost in half for the same CO2. Okay? So remember, we're causing intrathoracic pressure, and so if we can drop our intrathoracic pressure, we may get more flow through the lungs. And so we were able to drop our pulmonary vascular resistance by about almost in half, and we had about a 30% increase in cardiac output, which returned back to its baseline. So the nice thing about this study is that you had a pre, an intervention, and a post, and the pre and post are the same. The only intervention change was a high-frequency jet ventilation. So this proved that just changing the mode of ventilation in and of itself was able to improve cardiac output because you did what? Improve preload and dropped your pulmonary vascular resistance. There's been multiple other studies with jet ventilation and congenital heart disease. This was done by a colleague of mine, Keith Kosis, and he looked at patients, 9 patients who had ARDS and congenital heart disease. So that's a bad combination. I mean, that has a huge mortality in the immediate postoperative period. And so what he showed that even within an hour on the jet, he was able to increase the pH from 7.4 to 7.56, drop the CO2, and drop the FiO2. And this is one of the things that people talk about with the jet ventilator. They worry, well, wait a minute, if I use lower mean airway pressure, I might drop the oxygenation. But if you actually use a similar mean airway pressure or slightly higher mean airway pressure, you actually can get a better oxygenation and still remove a tremendous amount of CO2. So there's two types of strategy. One strategy where I'm only worried about the right side of the heart, and so what am I going to do? Drop the mean airway pressure. There's a strategy where you say, I have lung disease and heart disease. You want to try to get your same mean airway pressure, but do it and get rid of your CO2 more easily. And in this situation here, when you use a quote-unquote ARDS strategy for congenital heart disease, you end up with a better FiO2 and a better CO2 because you're not really dropping the mean airway pressure. You're going with the same mean airway pressure or slightly higher, and you're getting low delta P, and you're removing CO2 like crazy. There was only one patient who failed to wean. That one went on to ECMO, and that patient died. There's another study that was done in 1994 where they took 9 infants and they randomized to conventional ventilation for high-frequency ventilation. And this were patients who were going on for BT shunt. And they showed that they were able to drop the mean airway pressure significantly, drop the CO2, and also improve the FiO2, the PaO2 in this patient population. So there's 3 different patient populations I've shown you that JET seems to be helpful for. 1 with pure RV dysfunction, 2 with ARDS, and 3, this is a patient population where they're trying to manipulate PVR in BT shunt patients. So really the JET ventilator has got a pretty long history. This is 94. Some of the other data was from 92. So there's a long history of a lot of patients who have been on high-frequency jet ventilation with congenital heart disease. The other mode of ventilation of high-frequency is high-frequency oscillatory ventilation. And as you know, there's a big delta at the machine, and this dissipates so that by the time you get to the alveolus, there's not much change in airway pressure. And so we use a mean airway pressure in this mode of ventilation, which can be higher than the mean airway pressure we use in conventional ventilation, but lower delta P at the alveolar level. So therefore, in theory, lower lung trauma. There's been a lot of controversy about how high-frequency oscillatory ventilation works with cardiac output. Many groups initially said that it decreased cardiac output. Okay? Then other people said, wait a minute, it may not change cardiac output. But none of these groups actually controlled for preload. And so when you started looking at the control of preload, remember how preload works. Here's conventional mechanical ventilation, right? With a right atrial pressure of here, and I'm getting this venous return. Okay? And so blood, it's going to come in from the SVC to the right atrium, the right ventricle, and out. Now, if I do high-frequency ventilation and I increase my mean airway pressure, what's going to happen? I'm going to increase my right atrial pressure and decrease the flow back to the heart. So therefore, the heart's going to get squeezed, and so there's going to be less preload, right? So if you increase your mean airway pressure, you will have less preload. And if that's what you do with high-frequency oscillatory ventilation and nothing else, you will drop your output. But if you give them volume, and if they can tolerate volume, which is important, can they tolerate volume or not? If they can tolerate volume, and you increase your right atrial pressure, your systemic venous pressure, you will have a new curve, and you will intersect back where you were with conventional ventilation, and you will resuscitate the preload and resuscitate the cardiac output. So high-frequency oscillatory ventilation, if you maintain the same preload, you will maintain the same cardiac output. So you have to have available for you a syringe of something you like, saline or albumin, to make sure you augment the preload. But the patient has to be able to tolerate that. If they're already massively fluid overloaded, you might not want to use that strategy. But that's the way to deal with the oscillatory approach. So cardiac output is usually maintained in a given patient. It may be decreased. If the mean airway pressure is significantly decreased, consider volume loading, or another approach to it is consider increasing your inotropes. So these 2 ways will allow you to use the oscillatory ventilator in these patients. The bottom line, if you improve oxygen delivery, guess what? If your cardiac output is maintained, your oxygenation is improved, you will improve oxygen delivery. And the bottom line is oxygen delivery. Okay? So you have to make some trades back and forth. What about nitric oxide? Well, you know that there's we talked about the endothelial cell injury that occurs in congenital heart disease, and you can give exogenous nitric oxide, which will increase cyclic GMP and result in smooth muscle relaxation and decrease your pulmonary vascular resistance. There's been a lot of studies on nitric oxide in congenital heart disease, a lot of confusing data back and forth, and so the jury still is not really out on its uses, even though a lot of us use a lot of nitric oxide. This is a study that was done in 2000 where they took 126 patients, and this is the largest study I know of using nitric oxide in congenital heart disease patients, where they randomized them. They believed that they had less pulmonary hypertensive crisis, less ventilator days, no difference in mortality. Patients with passive flow, bidirectional Glens, Fontans have the worst response. and maybe better in diseases where you have obstruction to pulmonary venous return, like total lumbar pulmonary venous return. They seem to have the best response to that. So even though we will try it on our patients who are at the most risk for the bidirectional lens of the Fontans, the results are really quite poor in that group. So it's not a panacea. It's important to use lowest dose possible, and it's important to use sildenafil as a bridge. We always use sildenafil to bridge off nitric oxide. That's based on a study out of Australia, which is really well done. So let's look at our strategies. We're almost done. If you look at the pathophysiological directed strategies now, we talked about systems, remember, cardiopulmonary bypass and all its effects. We talked about the parenchymal injury, the alveolar and the bronchial injury. We talked about the vascular injury, the pulmonary vascular resistance, and now let's look at our strategies. Let's say you have a patient who has decreased compliance, decreased mechanics. Our goal is going to be to optimize our mechanics, minimizing the hemodynamic effects of mean airway pressure and peak pressure for lung injury. So you want to make sure you're measuring what you're doing. I showed you some examples of terminal beaking and overdistension, and so said that that's bad. You want to maintain an ideal lung volume. You don't want your lungs to be collapsed because it takes so much energy and effort to open them up again, and you get hypoxic pulmonary vasoconstriction. By the same token, you don't want them too overexpanded because you're going to increase pulmonary vascular resistance. So titrate the PEEP carefully and optimize your mean airway pressure on your patient. Non-conventional modes, oscillatory ventilation and jet ventilation. If your mean airway pressure is greater than 15 to 20, then we think that you should be thinking about these two modes of ventilation in patients who have lung injury post-cardiopulmonary bypass. Other interventions, of course, FiO2 is an important component to it. Surfactant bronchodilators are being used very frequently, and we think that these are good approaches to patient population. My approach to patients who are on the ventilator prior to surgery is to give them surfactant, although that's somewhat controversial. And then nitric oxide, remember, you can use it, but be aware that the utility and the advantage of that has not been shown in congenital heart disease patients. What about patients who have RV dysfunction and pulmonary hypertension? Right ventricle hates the ventilator, hates positive pressure. So what we're going to do is we're going to try to decrease PVR and increase preload. So you want to decrease your main airway pressure. But be careful. When we first talked about this, people would bring patients back from surgery with zero PEEP. Well, that's not really that smart, because you want to keep your FRC open. So you don't want your lungs to collapse, because it's going to take so much energy to open that up again. They actually resulted in a higher mean airway pressure than even if they put on a low PEEP. So titrate your PEEP carefully. Avoid overdistension for sure. Alkalize your patient with bicarb, but not by lowering the CO2. Non-conventional mode, perfect mode for high-frequency jet ventilation. Any kind of RV dysfunction, pulmonary hypertension, the jet's the way to go. Lower mean airway pressure, better CO2 removal. Other strategy, nitric oxide, again, it's going to be helpful in certain patient populations, and vasoactive agents as well. What about the LV? Remember about the LV, it likes positive pressure. It can handle it, it helps it preload. So thoracic pump augmentation of left ventricular preload, in other words, giving a good tidal volume. You should be using a low ventilatory rate and a relatively high tidal volume, not the 4 or 5 per kilo. You want to go up to around 8. But don't start using 10 or 15 or 20 per kilo, which was published previously, because that's going to result in excessive pressure and excessive lung injury. Decrease LV outflow, decrease mean airway pressure, but maintain your functional residual capacity. So you don't want to decrease your mean airway pressure so low that you drop your FRC. Non-conventional modes, again, jet ventilation, oscillatory ventilation are very appropriate in patients who have LV injury. The methodology might be a little different. In an RV patient, where you're trying to lower mean airway pressure and try to improve filling of the right side of the heart, with this kind of mode of ventilation, you can actually increase mean airway pressure because it's going to improve filling and decrease the afterload. So it's a little different strategy. But you want to always optimize your oxygen delivery, and you always want to make sure that you're concerned about barotrauma. So you want to keep your PEEP pressures low. And inhaled medical gases, of course, are beneficial in these type of patients as well. So in summary, we've talked about cardiopulmonary bypass. We've said that babies are uniquely at risk for injury after cardiopulmonary bypass because of their size and because of the systems we use. We know that they're going to have parenchymal injury and a vascular injury. That parenchymal injury may be different depending on what type of disease process they had. We showed you an example of a VSD, which had one type of parenchymal injury, and a tetralogy of low patient that has a different type of injury. Vascular injury resulting in pulmonary hypertension used to be a very significant problem for everybody. Now that's reduced, but it's not zero. And that's the one that can cause mortality. So we need to really be aware of that. And then we showed you the strategies. RV dysfunction, low mean airway pressure. LV dysfunction, mean airway pressure is okay. And if you have ARDS on top of ventricular dysfunction, then you have to be really careful about how you're titrating your PEEP and you're titrating your peak inspiratory pressure. Thank you.